Well, these figures are from a reputable Chinese site that I've been following. And this number here, 52478, is the number of current confirmed cases of positive infection for COVID-19. This figure here is the accumulated confirmed cases, 5990, accumulated confirmed cases. This figure here is the suspected cases, but not formally diagnosed. This figure here, 8030, is the number of cases that are severe cases. This figure here, 6054, is the number that have confirmed recovered. Now, it doesn't seem that high, but we did look yesterday at how these figures are calculated, and the criteria for recovery are fairly exacting. The improving chest x-ray, no fever for 10 days, and 2 absent swabs testing for the presence of the virus in the upper respiratory tract. This figure here is the number of deaths so far. And that's the topic of today's video. So the topic really couldn't be more serious. Now, let's give a piece of information here. The Wuhan city government and Hubei province government state that there's a lot of unknown cases. So that they're acknowledging that there are cases that they don't know about, that there are unknown cases. So it's not that things are being hidden, I don't think, here. They genuinely don't know. There's actually more confirmed cases, or more cases that aren't confirmed that they know are out there. Now, what I want to do now is trying to keep with the evidence-based philosophy. Is we want to look at this study from Imperial College London. Well, it's more a report than a study. Now, Imperial College London are well known for their epidemiology and study of infectious disease. There's a lot of very high calibre academics and clinicians that they're associated with, and their official World Health Organization Collaborating Centre for Infectious Disease and Modelling. And this is their case summary report, the report 4, published on the 10th of February 2020. And what Imperial College are doing here, in collaboration with the World Health Service, is they are discussing the case fatality ratio, the case fatality ratio. So this is the ratio between the number of people that get the infection and the number of deaths. It's not mortality. Mortality is overall number of people that die. This is specific to people that have the infection, the number of cases that die. Now, the figures here are difficult. So for cases detected in Hubei, the case fatality ratio has been estimated at 18%. Now, as we've said, in the early stages of an epidemic, this does appear artificially high because of the large number of minor cases that aren't reported and officially diagnosed, and the cases that are possibly even asymptomatic. So it's artificially high, but that nevertheless is the figure that they've come up with for Hubei province, which of course is where the city is. That's their figures. Now, they've stratified these into 3 layers of figures. For cases detected in travellers outside mainland China, they've done some epidemiological modelling again. And the estimates of the case fatality rate in this are in the range of 1.2 to 5.6, which is a big range. And they do state this is with substantial uncertainty. Now, we're dealing with probably the best disease modelers in the world here, and they're not certain at the moment, so we certainly can't be. But they do go on and say that the overall case fatality rate in all infections But this is the total number of people infected. And that includes people that are asymptomatic, people without symptoms, or people that are symptomatic. Now, it seems that some people have an illness which is almost so mild, they don't really realise they've got it. They might feel a bit off, but they just carry on working. That's bad because it means they're infectious. It's good because it means they have a minor disease, and we hope many people do. Or, of course, it may mean they've yet to develop symptoms. And the official figures are still that it's 2 to 14 days for the incubation period. But there are some reports that it could be longer, which of course is concerning. But we're not sure yet. Now, the difference between these estimates does not reflect underlying differences in disease severity between countries. So I've been asked this quite a bit. Is there a racial difference in the way the disease affects people? And there is kind of a rationale for this, but I can't find any official data on it. We know the disease gets into the body through these ACE2 receptors, angiotensin converting enzyme 2 receptors in the lungs. That's the absorption site. That's how the virus. So that's the ACE2 receptor. The virus gets into there, and from there the virus gets into the cell. That's the way this works. And I have heard reports that research has shown that there's different numbers of ACE2 receptors in different races, but I can't find a proper peer-reviewed reference for that. So until I find a proper peer-reviewed reference for it, I can't accept that. So as far as we know, this is going to affect all races the same, and certainly the data from the accumulated cases on the cruise ship in Japan would seem to indicate that it's certainly no respecter of races. Depends on the severity of different, the sensitivity of different surveillance systems. Depends on that, and different levels of severity and clinical cases, clinical care offered to severe cases. So what this means is clinical care for the severe cases can be life-saving, is life-saving. And different levels of clinical care being given. So there's different sensitivities of surveillance, which make the figures uncertain, and there's different levels of clinical care which will affect the death rates. I'm going to talk more about the ratio of severe cases in a minute. It's still around about 15%. Many poorer areas, of course, can't cope with the current morbidity and mortality they have, the sickness and death in their own areas. A large influx of people are simply not going to get the care they require in many poorer areas, and the disease is going to propagate. And from this data here, in the absence of good clinical care, the death rate is going to be much higher. Imperial College, in collaboration with the World Health Organization, do say this is tentative, but it's the best we've got at the moment. All estimates rely on limited data on the typical time intervals from symptoms to onset of death or recovery. So there's a big delay here. For example, Dr. Lee, it looked like he was there was a lag of 27 days between him catching the infection and his tragic departure from us. The time lag. Now, taking this data from the Chinese site that we've just looked at, just a couple of sort of back of the envelope calculations really. So this one is taking the number of the number of deaths and the number of confirmed cases, and that gives us a death rate of 2.3%. On this calculation, we've taken the confirmed cases and the suspected cases because, as I've said before, we have no reason to doubt our brother and sister clinicians in China are not highly skilled at diagnosing this condition. So that would give us an actual figure of 73,335 cases. And if we calculate that with the known death rate, that will give us a death rate currently of 1.86% from these calculations. And the other thing I've done from this morning's figures is I've calculated the number of severe cases. So these are the number of severe cases. These are the ones that are going to require clinical care, whose life will depend on good clinical care, compared to the confirmed cases, and that gives us 15.3% of severe cases. So of everyone infected from the Chinese data. So basically, if we have 100 people infected, then 15 of those are going to be severe, and of those 15, around about 2%, around 2 are going to die. That's what it means at the moment. So for 100 infections, 15 severe cases, 2 deaths. Now, other figures are showing that the death rates are lower than that, around about 1%. In fact, that's what we're saying. That's what Imperial College is saying, 1%. So hopefully that's true, and that means that the actual number of severe cases that die is just 1%. And we can rely on their modelling much more than we can rely on my basic calculations. They take in lots of factors that I'm not aware of. So that's where we're at. It goes without saying, even in Western countries, we don't have the capacity to look after 15.3% of a large outbreak. So our chief medical officer on the radio this morning was saying we are cautious. It's very much a matter of if this arrives in our country, in the UK or in other Western countries, not a matter of when. That's what he's saying. But he's saying also at the same time, which is somewhat paradoxical in my view, that our strategy is containment and delay. Because if we can contain, we can delay the spread of the infection. And when spring and the summer months come around, that will be on our side, because we know the virus survives less well in warmer environments. And we also, my understanding is that people are less, because they haven't got runny noses, they've got a better blood supply to their nose and things, they're less likely to catch the infection in the first place. So summer will be on our side, so we need to contain as much as possible and delay as much as possible. Now, I hesitated to put this next one in, but I'm just going to finish off with it. Case fatality ratio in previous epidemics. So other coronavirus epidemics, SARS, the severe acute respiratory syndrome, case fatality there was 9.6. Good thing about that was it didn't spread didn't spread as readily, because it's well, it did spread as readily, but people only spread when the people were ill, so it was easier to identify, whereas now we have asymptomatic transmission. MERS, which is hard to catch, has got a terrible death rate, 32%. Most cases of this now are direct zoonosis from camels in Arabia. Ebola, now these are the figures from the Democratic Republic of Congo as of the 20th of February, so these are bang up to date. For 3,431 cases with 2,253 confirmed deaths. That gives us a case fatality ratio of 65.7% in the current Ebola outbreak in Democratic Republic of Congo. In that situation, it's very much complicated by the security situation. Severe lack of security situation. Spanish flu. This was influenza, 1918 to 1919. This killed 50 million to 100 million people. No one's really sure, all around the world. Started in a chicken farm in the United States and was largely spread as a result of the First World War, but killed way more people than the First World War. Case fatality there was 2.5. That was a particularly bad influenza. Seasonal influenza, about 0.02 roughly. see different figures on this. And I don't know why I put this in, but bubonic plague, the famous Black Death of old, came to my country in 1348. Another outbreak in 1665, but various outbreaks in different periods of time. A death rate of 30 to 60% without antibiotics. With antibiotics, the death rate from that would now be essentially zero because it's bacterial. Disease caused by Yersinia pestis bacteria. So that's just a quick update on case fatality rates. So we're hoping that the death rate is going to be down at 1% or lower, but we're not yet certain.